Hello, everybody. Dr. Mayank Vats, are you here with us? Hello. Unfortunately, we can't hear you. Oh, great. We see you and we see your presentation. Can you tell something for us to check the sound? Can you hear me?
Yes.
Okay, great. I'm glad to hear you, glad to see each of you, dear students. Nice to meet you. I hope in future we will see each other in offline format, but for today we are doing such a great lecture with our new friend of our university, Dr. Mayank Vats. I want to introduce you to our student. This is, like I said before, new friend of our university, and we are doing our lecture, and he will tell you a lot of interesting information during next hours. And a little bit information about him. It's his first and foremost goal is to utilize his professional knowledge and interpersonal skills in order to provide highest degree of patient care and satisfaction. Having worked in a busy tertiary level teaching hospital and multi-specialty corporate hospital as a consultant, he has been exposed to a complete spectrum of respiratory, critical care, and sleep medicine. He finds this field extremely interesting and challenging, and hence he has developed special interest in its application for the benefit of patients. This is also an area which he feels requires further training. He wished to work in environment. Sorry, guys, please, can you mute your microphones? And he is about to improve his skills, improve your skills, and provide a structured teaching and training program, broaden his vision, and keep him abreast with latest development in this specialty. So the floor is yours, Dr. Mayank Vats. I'm welcoming you to start this great lecture. Thank you for the opportunity to do this for our students. We really appreciate it. And as I said before, hope to see you in future offline and produce as most effective education process with our students, which are great. We are there, we are happy that they are here with us and more students are connecting. So I think you can add a couple words about yourself and start such a meeting.
Shall I start now, sir? Am I audible, sir?
Pardon?
Am I audible?
Yes.
Okay. Good afternoon, all. It is my pleasure and honor for me to organize one lecture on community-acquired pneumonia for the esteemed Kyiv University. And I would like to first of all thanks to all the organizers and the faculty and the dean and principal of the medical institute to give me an opportunity to present the lecture. I would like to present community-acquired pneumonia, diagnosis and management. First of all, because this is first interaction between me and all of you, so I would like to give my brief introduction. I have published more than 150 international and national research articles in peer-reviewed journals. I have edited 5 books, including 2 books on COVID, and 3 books are under pipeline, under preparation. I have been honored with many awards during 2021 with World Book of Record London, UK, Sheikh Hamdan bin Mohammed bin Rashid Appreciation Award for committed work during COVID in UAE, Indian Book of Record for the highest number of publication during last 1 year, and this record is under consideration in Asia Book of Record and also in Guinness Book of Record. I received certificate of appreciation from Indian Society of Critical Care Medicine, Maharana Award, and many appreciation from DHA and Infectious Disease Unit and many other organizations for my work in the dedicated work during COVID pandemic. I'm a member of various editorial board of international journals, including the prestigious American Thoracic Society Journal. I'm expert commentator for ATS articles on COPD and asthma, and I'm editor of various journals like Malaysian Interventional Pulmonology Journal, Asia Pacific Pediatric Interventional Journal, Journal of Bronchology and Interventional Pulmonology, and many more. Now, let's start the community-acquired pneumonia. The outline of my today's talk would be, first of all, how to diagnose community-acquired pneumonia. Second, what should be the site of care of community-acquired pneumonia patient? What tools should be applied for the risk assessment for community-acquired pneumonia? What diagnostic tests are needed? And how to manage severe community-acquired pneumonia? First of all, we'll start with the case history. A 53-year-old male who's a smoker with a 20-pack year history, with history of cough and yellow-green sputum, high-grade fever, 39 degree, dyspnea and pain on breathing, comes to emergency. His saturation was 78%, and on auscultation, it revealed bronchial breath sounds with coarse crepitations on right side. Chest X-ray was done in the emergency, which reveals right mid-zone consolidation. So this is the X-ray which was done in the emergency. So what would be your diagnosis? Anyone from the audience, from the students? So it's pneumonia, community-acquired pneumonia. So how to define community-acquired pneumonia? It is an acute infection of the pulmonary parenchyma that is associated with symptoms of acute infection accompanied by the presence of an acute infiltrate on the chest X-rays or auscultatory findings which are consistent with pneumonia. Like patient may be having bronchial breath sounds, or patient may have localized crackles on auscultation, which suggests that patient has something ongoing inflammation in the lungs. This is very important to note that this definition fits for the patient who is not hospitalized or residing in a long-term care facility for more than 14 days before the onset of symptoms. So this is very important to know that patient for community-acquired pneumonia, the patient is coming from the community, is not coming or residing in a long-term care facility, or he was not recently hospitalized. Because in such cases, the diagnosis would be either healthcare associated pneumonia or nosocomial pneumonia. So our line of management will change. The community-acquired pneumonia could be caused by viral infection like COVID-19. We recently saw bacterial, any Streptococcus pneumoniae, Staph aureus, and any other bacteria can cause pneumonia. Mycobacterial, fungal, etc. It could be non-infectious in etiology. Then we call it as pneumonitis. Then we don't call it as pneumonia because it is not infective. So that's why it is called as pneumonitis, like chemical pneumonitis, aspiration pneumonitis. Later on, such pneumonitis may get superimposed secondary infection. Then it is labeled as pneumonia. So in this diagram, you can see the infected lung here. It is dense in color and consolidated. Similar sort of findings we can see in the chest X-ray, where there is a dense consolidation in the right lower lobe. And we can see some degree of air bronchogram, which is pathognomic of pneumonia. So this X-ray is consistent with right lower lobe pneumonia. How to classify the pneumonias? So very easy classification: community-acquired pneumonia and nosocomial pneumonia. Earlier in 2007, the ATS, it's a guideline recommended healthcare-associated pneumonia, hospital-acquired pneumonia, ICU-acquired pneumonia, and ventilator-associated pneumonia. Now it is broadly categorized into community-acquired pneumonia and nosocomial pneumonia, which includes all these pneumonias like healthcare-associated pneumonia, HAP, ICU pneumonia, and VAP. So what is the epidemiology of community-acquired pneumonia? Usually 4 to 5 million cases reported annually globally throughout the world, with resultant 500,000 hospitalization. And out of these 4 to 5 million cases, approximately 20% patient require admission, with resultant 45,000 deaths annually throughout the world. Fewest number of cases is reported in 18 to 25 year age group, means adult population. Usually they don't have pneumonias, or usually they don't have severe pneumonia because of the good immunity. Highest incidence of pneumonia is reported in either children or in the elderly population because of lower degree of immunity. Mortality is very high, disproportionately high in elderly population because of the comorbidity and the immunocompromised status of the patient. The overall mortality in pneumonia is around 2 to 30%, depending upon how sick is the patient, how bad is the pneumonia, and what are the underlying comorbidities. Hospitalized patient, usually they are sick and they have very severe pneumonia, so they have high mortality. The mortality rate is less than 1% for those patients who doesn't require hospitalization. Means these patients are less sick, less severe, so they don't require hospitalization, and hence the mortality is also low. Usually the community-acquired pneumonia has two types of presentation. The classical presentation is sudden onset of symptoms with high degree of fever, shaking, chills. Patient may have pleuritic chest pain, shortness of breath. Patient usually have productive cough with blood tinged or rusty sputum or purulent sputum. General condition of patient is not that good, and these patients have high mortality, up to 20% cases, especially in those patients who have bacteremia. Usually the most common causative agent is Streptococcus pneumoniae. The other type of pneumonia, which we commonly call as atypical pneumonia, usually they have gradual and insidious onset, low-grade fever, dry cough, no blood tinge in the sputum. They have usually good general condition, and they can come to walking as a walking patient in emergency or in your outpatient department. They have low mortality, except in cases of legionnaires. The causative agents usually are mycoplasma, chlamydia, legionella, rickettsia, and virus. So this is a broad classification of community-acquired pneumonia into classical community-acquired pneumonia and the atypical community-acquired pneumonia. Acute bacterial pneumonia, the classical patient usually are either the children or over the age of 40 years. They have abrupt onset of symptoms, as I told earlier. The cough is usually productive and purulent. However, it can be rusty. Rusty sputum is a classical finding in Streptococcus pneumonia patients. Rigors and fever are present. On clinical examination, on X-ray, consolidation will be present. Patient usually have elevated WBC with neutrophil predominance, and the chest X-ray may reveal alveolar consolidation with air bronchogram. So what are the common pathogens involved in the community-acquired pneumonia? Strep pneumonia is the commonest pathogen. It accounts for approximately 60% of the cases of community-acquired pneumonia. H. influenzae, chlamydia comes second, and legionella. So all these four pathogens are the commonest cause of community-acquired pneumonia. Hence, when we are managing the patient of community-acquired pneumonia, we should always keep in mind to have coverage, to give coverage for the strep pneumonia, H. influenzae, chlamydia, and legionella. Staph aureus, mycoplasma, gram-negative bacilli, and viruses may also cause community-acquired pneumonia, however, in with less frequency. In 40 to 60% of patients, usually we don't have causative agent identified, and 2 to 5% patients, they have 2 or more agents identified on the sputum culture or on the blood culture reports. So these are the cause. So this slide is important to remember that these are the 4 pathogens which are commonly caused, which commonly causes community-acquired pneumonia, and hence it is very important to cover them with the antibiotics. Streptococcus pneumoniae, usually 2/3 of community-acquired pneumonia are due to Streptococcus pneumoniae. On gram stain, it shows as a gram-positive diplococci in chains. However, if the gram stain is showing gram-positive diplococci in clusters, then we should always think of Staph aureus, which is definitely more deadly bacteria and more fulminant course as compared to strep pneumonia. The patient has typical symptoms: malaise, shaking, chills, fever, rusty sputum, pleuritic chest pain, and productive cough. Chest X-ray usually shows lobar infiltrate with involvement of one lobe or maybe multilobar involvement. Patient may be immunosuppressed, host like HIV patients or those who are receiving chemotherapy or those who are on long-term steroid treatment. Usually 20 to 25% of these patients may have bacteremia with serious complications and high risk of mortality. So these patients who have bacteremia, these patients may have risk of endocarditis, they may have a risk of septic arthritis, they may have risk of septic embolus in the brain and at any other sites in the body. So these are very important to take into consideration, and it has poor prognosis. Staph aureus community-acquired pneumonia, if it is community-acquired MRSA, it's a big problem and it could be dangerous. Staph aureus community-acquired pneumonia patient usually comes as a post-influenza complication. They present in bad shape, usually comes with a pneumonia severity index of class 4 or 5. This pneumonia severity index, I'm going to tell you later how this is a classification of how to classify the pneumonia based on the severity. Staph aureus community-acquired pneumonia patients are usually immunocompromised host, or they may be having underlying comorbidities like poorly controlled diabetes, elderly population, or chronic heart failure, chronic liver failure, or chronic kidney disease. So community-acquired MRSA is a big problem because it particularly releases a proteolytic enzyme. We call it pentine valentine leukocidine, which causes necrosis of the lung parenchyma, and these patients are at high risk of getting disseminated metastatic infection. CA community-acquired methicillin susceptible staph aureus can also occur, but this is not a big problem. So those patients who are having community-acquired MRSA, these patients may have empyema and necrosis of lung with the cavitation. This is a classical finding. The patient comes with the immunocompromised status, uncontrolled underlying comorbidities, and empyema and necrosis of lung. Usually, patient has multilobar involvement. Multiple pyemic abscess can also happen, like in the skin and soft tissue, in the bones, septic arthritis. These patients may present with hypoxemia, hypoventilation, hypotension. So it is very important to recognize early and to treat early. Vancomycin and linezolid are the drug of choice for MRSA pneumonia. Now this table I'm showing special features, although these are not pathognomic, but usually they suggest us about the tentative involvement, which pathogen is causing the problem. Like if the patient is coming with typical signs symptoms of pneumonia, usually the causative agent is Strep pneumoniae, H. influenzae, or Mycoplasma catarrhalis. Strep pneumonia is commonest, but however, the penicillin resistance is a big problem worldwide. Usually more than 20% or 25% of these Strep pneumonia cases have penicillin resistance. Atypical community-acquired pneumonia usually caused by Mycoplasma, Legionella, and these patients usually have extrapulmonary manifestations like confusion, hyponatremia, or other electrolyte abnormalities, or liver abnormalities, liver function abnormalities. Blood tinge sputum is classical of pneumococcal pneumonia. However, it can occur in Klebsiella and Legionella as well. H. influenza, usually they may have mild to moderate pleural effusion. Staph aureus, Klebsiella, and Pseudomonas, they are not found in the typical host. Typical host, I mean that otherwise young immunocompetent host. So these bacteria are usually involving the immunocompromised patients with underlying chronic comorbidities. Staph aureus, if the patient is coming to us with a post-viral influenza, history of post-viral influenza, or very serious community-acquired pneumonia, then we should always raise suspicion for Staph aureus. Klebsiella pneumonia, those patients who are having chronic alcoholism, these patients are prone for Klebsiella pneumonia. Pseudomonas aeruginosa, it is common in those patients who have chronic suppurative lung disease, cystic fibrosis, or those patients who have nosocomial pneumonia. Aspiration pneumonia, these are usually caused by multiple pathogens, including gram-negative bacilli. So this table indicates, however, it does not classically tell us about the potential involvement by which pathogen, but definitely it indicates us something about the how the patient present to us and how the radiological picture, how the clinical picture of the patient is there. According to that, we can just it helps us to guide about our treatment and gives us some suspicion of the likely pathogen involved. What are the risk factors for hospitalization and mortality? If the patient is elderly or child, then it is risk factor for hospitalization and mortality. Those patients who have underlying asthma, COPD, steroid or bronchodilator use, they have high risk of hospitalization. Patients having chronic lung disease, chronic heart disease, congestive heart failure, renal disease, diabetes, neoplastic disease, they have high risk of hospitalization and mortality. Those patients who are smokers and alcoholics, those patients who are having bacteremia, which is especially true for Strep pneumonia. If the patient is having community-acquired pneumonia with MDR pathogens like Staph aureus, MRSA, or Pseudomonas, these patients has likely requirement for hospitalization and high mortality. Extent of chest X-ray involvement is very important. If the patient has multilobar involvement, there are fair chances that patient may run into high complications and mortality. Immunosuppressed patient, either due to disease or medicine, may have high degree of mortality, and those who are residents of long-term care facility, nursing homes, and old age homes, these patients are having high risk factors for hospitalization and mortality. So it is very important to remember these patient group, those who are having high risk of hospitalization and mortality, in order to treat them early as possible with early empirical appropriate antibiotics. So how to evaluate the patient of community-acquired pneumonia? First of all, we should always go for the detailed history, complete physical examination, and the chest X-ray. If there are no infiltrates, we should always search for the alternate diagnosis. If there are infiltrates present or clinical evidence of community-acquired pneumonia, we should evaluate the patient for whether the patient requires admission or not. So it is very, very important to decide about the site of care depending upon the severity of the problem and based on the underlying physical condition of the patient and the underlying comorbidities of the patient. These two scores, Pneumonia Severity Index and Curve 65 scores, these are very important scores to decide about site of care. So based on these scores, which I am going to tell you later in the coming slides, we can decide whether the patient can be treated as outpatient or patient requires medical ward admission or patient requires ICU admission. So how to calculate these scores, I'm going to tell you now. What are the usual laboratory tests are carried out? Chest X-ray, PA view is the standard of care. Lateral view, if required, then we can go for the chest X-ray lateral view also. Patient should have CBC with differential counts. We should always do the renal function test, including blood urea, nitrogen, creatinine, and electrolytes. We do the fasting blood glucose or postprandial blood glucose, liver enzymes, ABG serology, and others as indicated. Inflammatory markers can also be done in order to see the extent of the severity of the pneumonia. However, CRP and PCT does not have any significant role in the prognostication of the pneumonia patient. Septic screen should be taken for those patients who are requiring hospitalization either in a medical ward or in the ICU. Gram stain and culture of sputum should be obtained and 2 sets of blood culture should be taken. Urine culture can also be taken or urine antigen test can be done for the Legionella and Mycoplasma. Oxygen saturation should be monitored. So what is the value of gram stain of sputum in cases of diagnosis of community-acquired pneumonia? The gram stain of the sputum help us to broaden the antibiotic coverage. In cases of strep pneumonia infection pneumonia, the sensitivity is 57%. However, it has very high degree of specificity, 97%. And for H. influenza pneumonia, it has high degree of specificity, 99%. So it helps us when the gram stain report is available, it helps us to broaden or revise our treatment. If we are not covering the patient with the strep pneumonia coverage or H. influenza, it helps us to do the proper antibiotic coverage. So it helps, gram stain is very useful test to help us to broaden the coverage of the antibiotic, and it is rapidly available test. The positive predictive value is very high. The negative predictive value is not that much high. So it is important to always evaluate the gram stain of the sputum. However, it is very it is unfortunate that good sputum sample is obtained only in around 40% of patients with pneumonia. The value of chest X-ray usually needed to establish the diagnosis, and it is a prognostic indicator as well. Suppose if the patient has underlying multilobar involvement, or if the patient has any complication of pneumonia like empyema or pleural effusion or distant pulmonary metastasis, septic emboli, so then it helps as a prognostic indicator as well. It is also used to rule out other associated disorder like underlying pulmonary edema, underlying interstitial lung disease, or any other pathology. It may help or gives us a clue about the etiological diagnosis as well. So how it helps us, how the infiltrate patterns help us to identify the pathogens. If the patient has lobar pneumonia, means complete involvement of one lobe or multiple lobes, it could be strep pneumonia, Klebsiella pneumoniae, H. influenzae, and gram-negative bacilli. If patient has patchy involvement of bilateral lung parenchyma, then it could be atypical pathogens or viral or Legionella. So interstitial pattern comes with viral pneumonia like COVID. We saw in COVID patients as well, PCP, Legionella. Cavity lesions are found in anaerobic infection, Klebsiella infection, TB, Staph aureus, and fungal infection. Large effusions are common with Staph aureus, anaerobes, and Klebsiella. So the chest X-ray gives us some idea about the likely pathogen involved and to taper our antibiotics or to escalate the antibiotics to optimize the management of the patients and to do necessary tests required for the diagnosis of the pathogens. Like suppose if the patient is coming to us with a cavity lesion, then we should always do the TB sputum for AVP smear and culture, and we should always do the TB PCR in order to rule out TB. Or we can also send the KOH smear of the sputum in order to find out whether fungus is the causative pathogen. So chest X-ray gives us a fair idea about the possible pathogen. Here, I'm showing you the normal chest X-ray and the mnemonic consolidation, faint mnemonic consolidation in the left lower lobe. If you see, this is normal chest X-ray. Both the lungs are equally visible. This is aortic knuckle. This is our ascending aorta. This is pulmonary artery, left lung, right lung, splenic shadow, and the liver shadow. Both the costophrenic angles are clear. There is no obvious consolidation in the chest X-ray. But if you see this X-ray, you will find faint opacities in this part of the lungs with the obliteration of the retrocardiac silhouette. Like here, you can see the retrocardiac silhouette, which is not evident over here. So this is definitely a left lower lobe pneumonia, although mild. And when we compare this area with the contralateral lung, it is more white, more opaque, which indicates that patient has underlying left lower lobe pneumonia. How we can see the lobar pneumonia in the X-ray? If you see this X-ray, it is showing right upper lobe consolidation with elevation of the horizontal fissure of the lung. It means there is partial collapse also of the right upper lobe. If you see these black markings, these are the air bronchogram, which is pathognomic finding of the air space consolidation. So this is right upper lobe involvement with partial collapse of the right upper lobe. In such cases, we should always rule out endobronchial lesion as well. If you see this X-ray, this almost complete opacification of the left lung. So this is left lower lobe pneumonia, and we can see the air bronchogram. These are the bronchus filled with the air, which when we see in the X-ray, it looks like black shadows running as per the bronchial branching pattern. So this is classical finding in the chest X-ray of the pneumonia patient, and we call it air bronchogram. What is the value of the lateral views in the chest X-ray? When we want to localize the infection, which lobe is involved, it is more of theoretical purpose rather than the clinical purpose. But when we want to localize, we should go for the lateral views. So here, if you see, the patient has right middle lobe involvement, and here, if you see, the consolidation is bounded on the top by the horizontal fissure and on the down by the oblique fissure. So it is lateral view of the right middle lobe involvement. How to find out about lobar versus segmental involvement of the community-acquired pneumonia? If you see here, it is completely right middle lobe involvement. We cannot see the heart border very clearly. This is called as right middle lobe involvement, and this shadow, this sign is called as silhouette sign. So in this patient, silhouette sign is positive. It means the right middle lobe is involved. Here, if you see, it's a very small shadow, and it is consistent with the medial segment of the right middle lobe involvement. So it is called as segmental pneumonia. Again, one X-ray showing multilobar, bilateral multilobar involvement. If you see over here, it is the complete lobar involvement, and here also it is lobar involvement. If you see on this X-ray, it is showing left upper lobe involvement by dense consolidation. Okay, this lung is reasonably apparently healthy. However, this is also having some degree of involvement by the mnemonic process. When we compare this left side with the right side is more clear, and the left side is showing faint opacities. So it is having primarily left upper lobe involvement with partial involvement of the left lower lobe as well. If we see this X-ray lingular consolidation, here we are unable to differentiate the left heart border, which is again the silhouette sign is positive, and which occurs in the lingular consolidation. This X-ray, we can see the pneumatococcus. It's a air lucency within the area of consolidation, and this is called as either pneumatococcus or early breakdown or maybe early cavity formation. This is common with the Staph aureus pneumonia or with the tuberculosis pneumonia. Another type of pneumonic consolidation is called as round pneumonic consolidation. Here the shadows are reasonably well defined. If you see over here, these are it is in the right lower lobe, well defined, reasonably well defined shadows. However, this round pneumonic consolidation, the patient needs further evaluation if the patient is not responding to the antibiotics within 7 days or within 7 days, he may require further investigation. This X-ray shows bilateral diffuse alveolar involvement. If you see, we can see all the faint opacities involving the left lung and the right lung as well. So this is diffuse alveolar involvement. We call it bronchopneumonia or bilateral, and it indicates either viral involvement or interstitial lung pattern of the pneumonia. It's expression pneumonia. If you see this pneumonia, this is elderly patient with bilateral lower lobe pneumonia and secondary to aspiration, which is common in the lower, in the dependent part of the lungs and in the lower part of the lung. So these X-rays consistent with the aspiration pneumonia, along with the clinical picture of the patient and the presenting history of the patient. This X-ray, whenever such patient comes to us, we should always think of viral pneumonia, like for example, Pneumocystis carinii pneumonia. Nowadays we call it Pneumocystis jirovecii, or CMV pneumonia or COVID pneumonia. These patients usually have bilateral parenchymal infiltrates in diffuse pattern. Radiation pneumonitis, this is a special form of pneumonia when the patient has radiation treatment because of lung cancer or breast cancer. The patient usually have if you see the X-ray, the pneumonia is primarily involved into this part of this. It is also called as square pneumonia, and it is secondary to the radiation pneumonitis and radiation fibrosis. Coming over to complication pneumonia, if you see this X-ray, we cannot see the blunting of the, we cannot see the CP angle very clearly as we can see over here. So we call it blunting of the CP angle, which is consistent with the pleural effusion. But if the patient is coming to you with a very toxic sign symptoms with elevated WBC, elevated septic markers, and then we can suspect empyema on the left side. In such cases, we should do the ultrasound guided pleural drainage in order to find out whether it is real empyema or it is only pneumonic effusion. Lung abscess. If you see this area, air fluid level, it is all necrosis over here. We cannot see any lung parenchyma. We cannot see any vascular markings over here. So it's a big area of lung abscess along with the air fluid level. We label it as a lung abscess. The differential diagnosis of such patient is loculated hydropneumothorax. But again, we have to go back into the history of the patient along with the underlying comorbidities and the presentation of the patient in order to find out whether it is lung abscess or hydropneumothorax. In lung abscess, usually the patient may have foul smelling, purulent sputum, while in hydropneumothorax patient usually gives a history of chest pain followed by gradually onset breathing difficulty followed by signs symptoms of infection like fever, elevated WBC and all the things. If you see this X-ray, it is showing right-sided empyema. CP angle is not clear over here, and we can see some homogeneous opacities on top of heterogeneous opacities on the right lower lobe. When the CT scan is done, it shows us empyema because if you see the visceral pleura is showing the enhancement. Okay, and this is the empyema. This is the fluid collection in the chest, which we label as empyema because of the visceral pleural enhancement. If the visceral pleural is not very clearly defined, then we can label it as a pneumonic effusion. So this involvement of the visceral pleura shows that there is a strong degree of inflammation ongoing in the pleural space, and we label it as empyema. So what are the management guidelines for the community-acquired pneumonia? The most important thing is rational use of microbiology and the laboratory test. We should always try to give pathogen-directed antimicrobial treatment. This line is very, very important. Early, appropriate, empirical antibiotics. Whenever we are treating the patient of pneumonia, always remember this thing. The antibiotic should be given as early as possible. It should be appropriate, means it should cover the likely pathogen, and it should be empirical when taken into consideration about the patient clinical history, patient's underlying comorbidities, and the presentation and the radiological picture of the patient. We should always try to cover all the pathogens, and later on we can always revise the antibiotic or de-escalate the antibiotic based on the culture report. Decision to hospitalize the patient should be based on the prognostic criteria like CURB 65 score, CRB 65 score, or pneumonia severity index. The supportive treatment for pneumonia should be IV fluids, maintain airway breathing circulation, hemodynamics, and oxygenation of the patient, blood sugar control, bronchodilators if needed, other treatment as needed, and manage the comorbidities. So in general, this is the standard of guidelines, standard management of the community-acquired pneumonia. What is pneumonia severity index? A large trial was carried out, pneumonia outcome research team port study, which revealed that pneumonia severity index is a very useful tool in order to find out whether the patient should be treated as outpatient, or patient should be admitted to medical ward, or patient should be admitted to medical ICU. So they took into consideration many factors like age in the years, and then they allocated different scores for those patients. Like for men who are 50 years of age, they allocated the points 50 minus 10 for the women. For NHS resident 10 points. Based on the comorbidities, they offered certain points to neoplastic, 30 points, liver disease 20 points, and like this. Clinical parameters, investigation finding, they allocated different points to all the parameters, and then they calculated the pneumonia severity index. So how to manage patient on the pneumonia severity index? It's in clinical practice, this is a very complicated score to calculate, and usually it is not a we are not doing it on day-to-day basis, but just for the knowledge purpose, for the port class 1 with the pneumonia severity index with no respiratory failure, the mortality is 0.1 to 4%, and patient should be given outpatient treatment. Those patients who are having class 2 port class with a pneumonia severity score of less than 70, the mortality is 0.6 to 0.7%, and these patients can also be treated as outpatient. The class 3 of the port class, which comes with a pneumonia severity index score of 70 to 90, may require brief hospitalization for 1 to 2 days. Class 4 and class 5 with the pneumonia severity index score of more than 90 require ICU inpatient care, and more than 130 requires ICU care. This PSI score is a complicated score to calculate, so it is not a practical tool to assess the site of care, to decide about the site of care of the patient. So this is very small and short and sweet mnemonic, curve 65. It is very easy to remember, easy to calculate, and easy to apply to see what kind of treatment patient requires. So curve 65, here C stands for confusion, U stands for urea nitrogen, R stands for the respiratory rate more than 30, B stands for blood pressure, systolic blood pressure less than 90, or diastolic blood pressure less than 60, and 65 stands for the age. We are giving one point to each, like 1 point for confusion. If the patient has confusion, 1 point. If the patient has 1 urea more than 30, then 1 point. If the patient is tachypneic having respiratory rate more than 30, 1 point. And in the similar way, we will allocate 1 point for each parameter. If the curve score is 0 or 1, patient doesn't require hospitalization and can be easily managed on the home treatment as outpatient basis. If the curve 65 score is 2, patient may need short hospitalization. Curve 65 score of 3, patient may need medical ward admission, and curves 4 or 5 require ICU care. So this score helps us to decide about whether the patient requires hospitalization or not, and in order to reduce the morbidity associated with hospital-acquired infections and to reduce the cost of the medical care of the patient. So this curve 65 score is very important score while treating the patient with the pneumonia. Suppose if we are seeing the patient in the peripheral healthcare center or in the emergency, we don't have the blood urea nitrogen levels. So we can cut short this score, CRB 65. So if the patient is confused, 1 score. Patient is tachypneic, respiratory rate more than 30, 1 score. Patient has blood pressure of less than 90 or less than 60 diastolic, 1 score, and patient is elderly more than 65. So we can make CRB 65 also. Here we don't need blood urea nitrogen level to decide about the site of level of care. So this score can be very useful for the PHC level. So suppose if the CRB 65 score is high, the PHC doctor can refer the patient immediately to the hospital for the admission to the medical ward or ICU care. So who should be hospitalized? Class 1 and 2 usually don't require hospitalization. This is as per the pneumonia severity index. Class 3 may require brief hospitalization. Class 4 and 5 require hospitalization. Now this slide shows us severity of community-acquired pneumonia patient with poor prognosis. So these patient warrants urgent attention, immediate treatment, and early appropriate antibiotics and the management of the vitals in the hemodynamics. Those patients who are tachypnic, having respiratory rate more than 30, if the PO2 FiO2 ratio is less than 250, how to calculate the PO2 FiO2 ratio is when we take the ABG sample, we take the PO2 level and what oxygen the patient is requiring. So based on that, we calculate the PO2 FiO2 ratio. If it is less than 250, it means patient is sick and he has severe pneumonia and he requires medical ward admission or ICU admission. Or if the if the PO2 is less than 60 millimeter of mercury on room air, then patient has severe community-acquired pneumonia with poor prognosis. Those patients who require mechanical ventilation, those patients who have multilobar involvement on the chest X-ray, patient presenting us with septic shock, hypotension, or requiring vasopressors for the resuscitation, those patients who have kidney involvement like oliguria or elevated blood urea nitrogen and altered mental status. So these patients are classified as very severe community-acquired pneumonia and have poor prognosis. So what are the criteria for ICU admission for severe community-acquired pneumonia? The major criteria, if the patient fulfills any criteria, like he requires mechanical ventilation, he should be admitted to ICU. Or if the patient is coming to us with septic shock, with the requirement of vasopressor, then also he should be admitted to ICU ward or high dependency care. If the patient has more than 3 minor criteria, then he requires ICU admission. Like suppose, for example, the patient is confusion or disorientation, blood urea nitrogen is more than 20, patient is tachypnic, temperature is either hypothermic, patient has severe hypotension, PO2 FiO2 ratio less than 250, multilobar involvement, WBC less than 4,000 or platelets less than 100,000. If in any patient more than 3 minor criteria are present, then he's a candidate for ICU admission or high dependency care admission. So what is a new treatment paradigm for the patients of community-acquired pneumonia? Most important thing, hit hard and hit early with appropriate antibiotics. As I told before, that we should always start the antibiotic early, appropriate, and empirical antibiotics. Short duration of treatment is required. De-escalate wherever possible. Whenever we get the culture reports available, we should try to devise the antibiotic and de-escalate the antibiotics in order to avoid emergence of multi-drug resistant microorganism. So all these objective 1 and 2 both are very important while treating the pneumonia patients. So what should be the empirical treatment for the outpatient pneumonia patient? Assume that patient is coming to us is a healthy young patient with no risk factor for the drug-resistant Streptococcus pneumoniae based on the local epidemiology reports or based on the previous history of the patient. Then we can offer patient macrolide or doxycycline and treat the patient as outpatient. In case if the patient has comorbidities or use of antimicrobials within the previous 3 months and patient comes with a region with a high rate of infection with macrolide resistant strep pneumonia based on the epidemiological pattern of that particular area or that particular country, then we should treat the patient with the respiratory fluoroquinolone, either levofloxacin, gemifloxacin, or moxifloxacin. These medicines are very useful to treat community-acquired pneumonia for the on the outpatient basis with the where there is high degree of macrolide resistance in the community. We as an alternate, we can give patient beta-lactam, high doses amoxicillin or amoxiclav is preferred. We can, if the patient requires hospitalization, we can give ceftriaxone or cefpodoxime, like 3rd generation cephalosporins, plus a macrolide or doxycycline. So these are the combination where we can offer beta-lactam plus a macrolide in order to combat the resistance of the macrolide as outpatient basis. Those patients who require inpatient treatment, non-ICU patient, either we can treat the patient with the respiratory quinolone or we can give patient beta-lactam plus macrolide combination, or usually the beta-lactam agents are 3rd generation cephalosporin like cefotaxime, ceftriaxone, etc. If the patient is having allergy to penicillin, then we can give patient respiratory quinolone or ertapenem is another option in those patients who have penicillin allergy. So this is the treatment, empirical treatment for the inpatient, those patients who doesn't require ICU admission. Those patients who require ICU admission, for those we should offer combination antibiotic like beta-lactam plus either azithromycin like macrolide or fluoroquinolone. For penicillin allergic patients, a respiratory quinolone and aztreonam can be given. So whenever we are admitting the patient in the ICU, always remember to give third generation cephalosporin or broad spectrum beta-lactam along with the beta-lactam is inhibitor plus either erythromycin or quinolones in order to cover atypical pathogens, because strep pneumonia and the atypical pathogens are the most common pathogens causing highest accounting for the highest community-acquired pneumonia. If we are suspecting Pseudomonas in the patient based on the previous history, based on the underlying comorbidities of the patient, so in such patient, we should always start the patient on the piperacillin tazobactam combination or cefepime or carbapenems plus either ciprofloxacin or levofloxacin. So this is very important to take whenever we suspect Pseudomonas. Like suppose if the patient has bronchiectasis or patient has history of Pseudomonas isolation in the sputum culture, or patient has cystic fibrosis or colonized with the Pseudomonas. So in that case, we should always offer piperacillin tazobactam or cefepime or carbapenem plus a combination of ciprofloxacin or levofloxacin, and then we can always add amikacin based on the severity of the illness and based on the kidney function. So as a second alternative, we can use above beta-lactams plus aminoglycoside plus azithromycin. Third option, we can use above beta-lactam plus aminoglycoside or anti-pseudomonal and anti-pneumococcal fluoroquinolone like levofloxacin. So depending upon the severity of the illness, depending upon the underlying lung disease, depending upon the underlying comorbidities, we have to choose the antibiotics. While treating severe Pseudomonas infection, we should always try to give 2 antibiotics which are anti-pseudomonal. Like in this case, suppose if I'm giving patient piperacillin tazobactam plus aminoglycoside, so it means 2 antibiotics are likely active against the Pseudomonas. So it is very important to cover Pseudomonas with the 2 antimicrobials. For those patients where we are suspecting community-acquired MRSA, like those patients who have uncontrolled diabetes, underlying comorbidities, they comes to you with a very toxic presentation on the chest X-ray showing multilobar involvement with cavitation, with pneumatoceles. So we are suspecting community-acquired MRSA. We can offer vancomycin or linezolid as a choice, initial choice for the treatment, and later on based on the culture report and based on the clinical response of the patient, we can always de-escalate or revise our treatment. For those patients who are having MSSA, methicillin sensitive staph aureus, beta-lactam and sometimes a respiratory quinolone will be enough until the susceptibility result comes. Those patients who require specific therapy with a penicillin-resistant semi-synthetic penicillin or cephalosporin can also be used for the MSSA. So MSSA is not a big problem, but CA-MRSA is always a big problem, and we should always have high degree of suspicion for toxic patient and for sick patient about the CA-MRSA. So what should be the duration of treatment? Minimum duration of treatment should be 5 days. It could be usually 5 to 7 days. When to stop the antibiotic? When the patient is afebrile for at least 48 to 72 hours. When patient should not have more than 1 CAP associated signs of clinical instability. Like patient should not be febrile, patient should not have tachypnea, patient should not have tachycardia, patient should not have any hypotension. So then we can continue we can think of stopping the antibiotics. Longer duration of therapy is required if the initial therapy was not active against the identified pathogen or complicated or the course is complicated by extrapulmonary infection. For example, suppose if we started the patient on the treatment which is not covering the Pseudomonas, and later on we found on the sputum culture or in the blood culture Pseudomonas. So then we can always revise the antibiotic. We should always revise the antibiotics, and longer duration of treatment can be given in the form of tazocin, piperacillin tazobactam, or 4th generation cephalosporins or carbapenems to cover the Pseudomonas. So summary of empirical treatment: if the patient requires outpatient treatment, any one of these 3 antibiotics can be given, either macrolides like azithromycin, clarithromycin, or doxycycline, or fluoroquinolone like levofloxacin, gemifloxacin, etc. Those patients who require general medical ward care, third generation cephalosporin like ceftriaxone, cefotaxime, plus a combination of macrolide should be offered, or patient could be given beta-lactam or beta-lactam inhibitor plus macrolide or quinolones. So macrolide and quinolone it should be used only either macrolide or quinolone should be used. We should not combine these two medicines together because these are given for the atypical coverage. But if we have high suspicion of Pseudomonas, then always I would prefer quinolones, either levofloxacin or ciprofloxacin, because they have good anti-pseudomonal activity. Patient in ICU, usually third generation cephalosporin plus macrolide or third generation cephalosporin plus quinolone is a preferred antibiotics. As an alternative, we can give beta-lactam or beta-lactam inhibitors plus macrolide, or beta-lactam and beta-lactam inhibitors plus fluoroquinolone. So if you see here, we are switching the therapy from third generation cephalosporin to either beta-lactam antibiotics or beta-lactam inhibitors. Fluoroquinolones are in the same place. So in order to remember, very easy to remember, those patients who require admission, we should give either third generation cephalosporin plus macrolide or fluoroquinolone. When to switch to oral therapy? Simple 4 criteria are there. When the patient has clinical improvement in the form of improvement in the cough, dyspnea, and clinical signs of the pneumonia. When the patient is afebrile on 2 occasions, 8 hours apart. When the WBC counts are decreasing towards normal, and patient has functioning GI tract with no nausea, no vomiting. And
ايش بتسوي لحالك انت ممكن اعرف؟
I'm sorry. If overall clinical picture is otherwise favorable, patient is hemodynamically stable, then we can switch to oral therapy while still the patient is febrile. So switching to oral therapy is a clinical judgment and based on the clinical improvement of the patient. Now coming over to 2007 ATS ITSA guideline and 2019 ATS guideline, what are the new changes in the 2019 guidelines? Sputum culture and blood cultures were recommended in 2007 for patients with severe disease, while in 2019 it is recommended in patients with severe disease and all patients where we are treating the patient for empirical MRSA and empirical anti-pseudomonal. So in those patients where a patient is presenting to us with a severe disease or we have high degree of suspicion of MRSA or Pseudomonas, we should always send sputum culture and blood culture. And later on, based on the culture reports, we should always revise the antibiotics. Macrolide monotherapy was a strong recommendation in 2007 guidelines, but here it is conditional recommendation based on the resistance level of the macrolides on the local epidemiological pattern. Use of procalcitonin and use of corticosteroid was not covered in 2007 guidelines, and in 2019 it is not recommended to determine the need for initial antimicrobial therapy, and the role use of steroids is not recommended until unless the patient has refractory septic shock. So these changes these things are very important to remember. Use of healthcare associated pneumonia was a separate entity in 2007, while in 2019, based on the clinical response, severity of the illness, and the prognosis of the patient, they included healthcare associated pneumonia into a common term called as nosocomial pneumonia. So they have removed the term healthcare associated pneumonia. The standard empirical therapy for severe CAP in 2007 guidelines were beta-lactam plus macrolide, and beta-lactam plus fluoroquinolone combination was given equal weightage. But in 2019, both were accepted, but stronger evidence in favor of beta-lactam plus macrolide combination. Routine use of follow-up chest imaging was not addressed in 2007, but it is in 2019 we recommend not to obtain the routine follow-up chest X-ray until unless we find any complication of the patient or patient is not responding or patient is slow to respond. Only then we have to do the X-ray. Otherwise, routine follow-up chest X-rays are not recommended. This is again slide showing what's new in 2019 guidelines. So initial treatment strategies for outpatient with communicable pneumonia, no comorbidities or no risk factor for MRSA or Pseudomonas, we can treat the patient with amoxicillin, doxycycline or macrolides. If the patient has comorbidities, then to give combination therapy, either amoxiclav or cephalosporin and macrolide or doxycycline, or monotherapy with quinolones. So these are the standard regimes for those patients as per the 2019 guidelines. Initial treatment strategies were further classified based on the severity of the illness, like non-severe patients and severe patients, and based on the based on the risk factor for the MRSA and Pseudomonas, and based on the risk for drug resistance. So if we see this table, the patients were classified into non-severe inpatient pneumonia and severe inpatient pneumonia. So the standard regime was beta-lactam plus macrolide or quinolones, and same here, beta-lactam macrolide or beta-lactam plus fluoroquinolone. If the patient has any history of prior respiratory isolation of MRSA or Pseudomonas in the sputum culture or blood culture, then to add MRSA coverage and obtain culture or nasal PCR to allow de-escalation or confirmation of need for continued therapy. And same is true for the Pseudomonas. So in such cases, we start the empirical coverage for the MRSA or Pseudomonas based on the high degree of suspicion on the previous reports and on the underlying pathology of the patient. And then we have to start the anti-MRSA coverage or anti-Pseudomonas coverage. And based on the culture report, either we have to continue if the Pseudomonas is coming positive or MRSA is coming positive, we have to continue the treatment. If it is coming negative, then we should de-escalate the antibiotics. Those patients who have severe inpatient pneumonia, start them with either beta-lactam macrolides or beta-lactam plus quinolones. Same, add MRSA coverage if patient has prior isolation of MRSA or Pseudomonas, so then add Pseudomonas coverage and to follow the culture reports, and then allow either to de-escalation or confirmation of continued therapy for the Pseudomonas if Pseudomonas is coming positive, or MRSA if MRSA is coming positive. Now coming over to those patients who have high degree of drug resistance. So non-severe inpatient pneumonia and severe patient pneumonia, same treatment regime like as discussed here. Then those patients who has recent hospitalization and parenteral antibiotics and locally validated risk factor for MRSA. So what we should do, we should obtain the cultures but withhold MRSA coverage unless culture reports are positive. If rapid nasal PCR is available, withhold additional empirical therapy against MRSA if rapid test is negative, or add coverage if test is positive and obtain the culture. So this is based on those patients who doesn't have any history of isolation of MRSA or Pseudomonas. However, they have recent hospitalization and use of parenteral antibiotics, or this locally validated risk factor for MRSA or Pseudomonas. So this is a separate group of patients. So we should obtain the culture, and then accordingly we should de-escalate the antibiotics or escalate the antibiotics. Those patients who have severe inpatient pneumonia, start beta-lactam plus macrolide or beta-lactam plus quinolone, add MRSA coverage. For severe pneumonia, we have to add MRSA coverage. This point is important to note. And here also we have to add coverage for the Pseudomonas. So for severe inpatient pneumonia, add MRSA coverage. For non-severe patient, don't add coverage unless we have positive reports. So this is the basic differentiation between these two groups. So here we are, for severe patient, we are adding MRSA coverage and sending the PCR and the cultures, and based on the reports, we are de-escalating the antibiotics or continuing the same treatment if the culture reports are positive for MRSA. For those patients who have Pseudomonas risk factors, we have to add coverage for Pseudomonas, and based on the culture report, we have to de-escalate or continue the treatment if culture is coming positive for the Pseudomonas. So these are very important changes in the 2019 ATS ITSA guidelines. Suppose if I am treating the patient with appropriate antibiotic, but my patient is not responding, then what should I do? So this is called as management of poor responders. So in such cases, I have to revise all the treatment regime, whether I'm treating the patient, whether my diagnosis was correct or not. So suppose if the patient is not responding even after 4 or 5 days of good antibiotics, so maybe there's possibility that my working diagnosis was not correct. So we should always consider non-infectious illness like pulmonary edema, pulmonary embolism, pulmonary infarction, or any other non-infectious pathology. Wrong pathogen. So if the patient is not responding to the treatment even after 3 or 4 days of antibiotics, so there could be possibility that what antibiotic we are giving to the patient, it is not covering the causative pathogen. So we should always consider less common pathogens like Brucella, Bordetella, and we should send the serological testing of the patient. Like we can offer HIV for the patient, we can offer serology for the Brucella, Bordetella, PCP, and other tests. Wrong antibiotics. It could be possible that we have not started the patient on the appropriate antibiotics. In such cases, the patient is not responding, and then we have to change or broaden the antibiotic coverage. Complication of the pneumonia is another factor where the patient is labeled as poor responder for the treatment. Suppose if the patient develops empyema, then he will become the poor responder. He will not respond so fast. If the patient develop any lung abscess or any other septic complication of the pneumonia, then also he will not respond as fast as a non-complicated pneumonia. So we should always, whenever we are encountering such patient, those who are getting adequate, empirical, appropriate antibiotics, after 3 days of the treatment, they are not responding in an appropriate way, then we should always revise our diagnosis. We should think of covering the pathogen. We should always consider thinking of escalating the antibiotics and to rule out complication. How to rule out complication? By doing CT scan of the chest, by doing chest X-ray. Suppose if the patient is going into empyema, which was not present on the initial presentation, then we have to offer him CT scan or ultrasound guided pleural drainage in order to find out whether it is empyema or pneumonic effusion. We have to offer bronchoscopy to the patient. Like patient may have endobronchial obstruction, like patient could may have underlying endobronchial tuberculosis or underlying endobronchial malignancy. So we have to think of doing bronchoscopy in such patients. So this is the management of poor responder. It is very easy to remember. Always consider these things. Wrong diagnosis, whether our diagnosis was correct, whether we are dealing with the correct pathogen or not, whether we gave the patient correct antibiotics or not, and if the patient is developing any complication. So in such patient, always revise your treatment regime, always revise your management modalities and do the needful. What are the non-infectious causes of fever with pulmonary infiltrate that may mimic community-acquired pneumonia? This table is also very important to remember. Pulmonary edema, pulmonary infarction, acute respiratory distress syndrome, pulmonary hemorrhage, lung cancer, metastatic cancer, atelectasis, radiation pneumonitis, drug reactions involving the lung, extrinsic allergic alveolitis, pulmonary vasculitis, pulmonary eosinophilia, bronchiolitis obliterans, and organizing pneumonia. We call it BOOP, B-O-O-P. So whenever patient is not responding to the treatment, we should always think whether the patient has pulmonary edema, pulmonary infarction. We have to again revise our treatment modalities, our management guidance, and all the things. Okay, and based on the clinical history, underlying comorbidities, underlying investigation like chest X-ray, CT scan, we can always find out what type of like if we are dealing with the non-infectious cause, not of the pulmonary infiltrate, which may mimic community-acquired pneumonia. What are the complications of community-acquired pneumonia? Patient may develop hypotension and septic shock. 3 to 5% of patient may have pleural effusion. Usually these effusions are clear fluid, which may have pus cells. 1% of patient may complicate by empyemothoracis, which is called as pus in the pleural space. Some patient will go into lung abscess, especially the patient with strep pneumococcal patients or Staph aureus patient or alcoholic patient. So lung abscess can cause destruction of the lung and may lead to chronic suppurative lung disease. Single enrobes, pseudomonas, multiple metastatic complications with the Staph aureus are very common. Septicemia can lead to brain abscess, liver abscess, and multiple pyemic abscess. So these are the complications of community-acquired pneumonia, and these complications should always be looked for and investigated for. So most important point, how to win the war against the community-acquired pneumonia. Most important point is early, appropriate, empirical antibiotic within 4 to 6 hours of the emergency encounter of the patient. Pneumonia severity scoring and classification of cases based on the CURB 65 score or CRB 65 score, as I discussed earlier. So this decide about the severity of the problem and whether the patient needs admission or not. Early hospitalization in class 4 and 5 of PSI score. Change antibiotic as per the pathogen and sensitivity pattern based on the culture report. Suppose if the blood culture shows Pseudomonas or MRSA, we have to escalate the antibiotic to cover Pseudomonas or MRSA. Arterial oxygen assessment by pulse oximeter or by ABG is important in the first 24 hours. Blood culture collection should be done in the first 24 hours prior to antibiotics. What are the other advice? Smoking cessation, pneumococcal and influenza vaccine should be given. What are the strategies for prevention of communicable pneumonia? All patients should be given advice for smoking cessation by referring them to, by verbally counseling them and officially referring them to smoking cessation clinics. All patients should be offered influenza vaccine, commonly called as flu shots. It offers approximately 90% protection and reduces mortality by 80%. Pneumococcal vaccine should be offered to those patients who are in the age group of less than 64 with comorbidities and high risk for pneumonia, and all patients, all elderly patients more than 65 years. So it is very easy to remember. All patients should be having influenza vaccine or flu shot on the annual basis, and pneumococcal vaccine less than 65 years of age with underlying comorbidity, and all patients more than 65 years of age should receive pneumococcal vaccine. And we should always try to optimize the chronic comorbidities like diabetes, chronic kidney disease, congestive heart failure. So try to optimize those underlying comorbidities so patient will be having less risk of developing future communicable pneumonias. So summary of all the diseases to which man is higher, those known in etiology possible if cure, capable of prevention, are for the most part caused by infectious agent. So this dictum again shows that most of the disease are preventable and treatable and usually caused by the infectious agent. So we should use antibiotic judiciously. Do consider local and national resistance pattern of antibiograms and revise therapy based on the clinical microbiological response in order to prevent the emergence of multiple drug resistance, and always consider prior exposure to antibiotic when choosing the antibiotic. Thank you very much. Any questions?
Thank you.
Please feel free to ask any questions.
Thank you, sir.
Okay, so if for now we have no question, I think the lecture was really effective and productive for students. One more time, Dr. Mayank Vats, I want to thank you and provide that the university is happy to see you, to work with you, to be like in such great cooperation, and what help and impact on our students in the best way. And I hope all who joined us during this meeting enjoyed it, get some interesting information that is useful, and I think people who join us today will be the best doctor in the world and will share their knowledge and skills and use it only in the best ways to do the great thing.
It was an absolute pleasure for me to share the knowledge, and I would be happy to answer any questions if it comes now or later on. I would be happy to answer all the questions in full details in order to clear all any confusion, any doubts of the students.
Good afternoon.
Good afternoon.
May I ask you questions?
Yeah, please. Please.
My name is Dr. Yaroslav. I'm a family physician.
Yes.
Thank you for your useful and helpful webinar. And I want to ask you about what guidelines do you use in your own practice? And also, do you use educational online resources such as BMJ, British Medical Journal, or New England Journal of Medicine, etc.? Thank you.
So while treating the patient of communicable pneumonia, we try always to strictly follow the 2019 ATS guidelines. Whenever a patient comes to us in the OPD or emergency based on the severity of the illness, we always categorize the patient based on the curve 65 score. We hospitalize the patient or treat the patient on outpatient, and we always try to strictly follow the guidelines as given by the ATS in Infectious Disease Society of America. Means in 90% or more than 90% of cases, we always follow the guidelines. Regarding the resources for the education and all, BMJ and NEJM are definitely very useful resources. But I would suggest, like in all specialty, as per my expertise and all the things, to follow all the guidelines as per the standard guidelines of Combinatoric pneumonia, for the tuberculosis, for any other disease, to follow the standard guidelines from the American Thoracic Society, British Thoracic Society, American College of Chest Physician. So standard scientific societies, and they usually update their guidelines. So we should always try to update ourselves by getting into the updating ourselves with the latest guidelines.
Thank you.
Welcome.
Okay, maybe any other student have some questions to our teacher, to our friend. Okay, so on this, I think we can finalize that it is very important to co-work and to be on the same page with international discoveries and any science, new science facts and information that they have, to be on the first step and to be the best doctor in future. I hope that our students will really appreciate it, will use as much as possible that university provide for them, because a lot of different activities we do, online lectures, meeting, etc. It's going to a studying process, their leisure, different curriculum, extracurriculum activities. I hope that you enjoyed it, and I hope in the nearest future, like in a month, to see all of you on a fly studying, visit our trainings of Center of Simulation Training and Assessment, because these trainings have small groups, but we do a big schedule for our trainings, and you can, if you didn't manage to get to previous, visit them in future, because this is very important to get this practice skills. And I think our doctor also supports this idea. And one more time, Dr. Mayank Vats, thank you very much. It was a great pleasure to listen to you. I hope that in future we will continue our working, and this is really very important for us that such people as you join our university and help us to produce the best doctors in the world. Thank you very much.
Thank you very much.
Thank you very much, everybody. Yeah, have a nice day.
I would like to ask one question. Like, do I have another lecture also, or it was only one lecture?
I will ask you, and I will connect you. Okay.
Okay.
Okay. Thank you very much.
Thank you very much. Have a great day.
Have a good day. Bye.
Bye.
Have a good day, sir. Take care.
Bye to all.